Hi, so my name's Jordine. I'm one of the GP trainees on paediatrics at St George's. So I'm presenting a case that we saw in August this year. The case was actually seen initially in A&E by one of the other SHOs who's on nights. So I saw this patient later on during their admission, but I'm going to talk through their presentation to A&E from kind of the eyes of a paediatric SHO, so we can kind of think about how we would manage this case. So this happened, this patient came into A&E, brought in by parents in August on a weekend at 3 o'clock in the afternoon. It was a 2-week-old baby who had been referred by the community midwife with concerns over poor feeding and weight loss. So if you guys want it to be interactive, feel free to answer questions, or if there's a group chat, maybe you can put it in the group chat. But first question is, what kind of, before you go and see this baby, what kind of causes of weight loss would you be thinking of in the neonate? So yeah, Sarah's said poor feeding. So failure to thrive. So I've come up with there's obviously a lot of reasons why a baby might not be gaining weight. Hypothyroidism is another one. I've come up with a list of differentials. Oops. So it could just be physiological. So babies do lose some of their birth weight in the first 3 to 4 days of life, but we would expect them to be gaining the weight back by day 10 of life. Ineffective feeding, as Sarah said, either mum's not producing enough supply or baby struggling to latch. Infection is always a cause for weight loss in the neonate. So in this baby, given it's 2 weeks, it would be late onset infection. GI causes, endocrine causes, hypothyroidism, as Nicola mentioned, CAH, a few metabolic causes, congenital heart disease, and possibly a neurological cause. So before going to see this baby, this might be a few things you're thinking of for the differential. So key questions that you might want to ask when you go and see the parents for a baby that's lost weight. Sorry, I didn't hear that one. Yep, so you want to compare it with the birth weight, feeding history, vomiting. Yep, so other symptoms like vomiting, reflux, diarrhea, bilious vomiting. So I've put a few key questions here. So the weight loss and the trend of the weight loss, the feeding pattern. So have they always been a poor feeder, or is this a new symptom? Are they still having wet nappies? Are there any associated symptoms? So signs of infection, fever, cough, breathing difficulties. Are they drowsy or floppy? Any colour changes, any vomiting? And would it also be good at this point to ask about a birth history? Are they preterm? Do they maybe have chronic lung disease? Are they prone to infection? So this baby, can't see my screen too well, 1 second. So this baby is a poor feeder since birth. The dad had said that she was initially struggling to latch on to the breast and wasn't taking expressed milk. The midwife had given advice and support and had given a feeding plan for formula milk. And actually it looked like baby was doing quite well with this initially. She was having 60 mils every 2 to 3 hours, which is reaching her maintenance fluids target. However, over the last 24 hours, parents had noticed that she had again drastically reduced her feeding. So she had had 60 mils 9 p.m. the night before, hadn't waited for a feed overnight, had a further 60 mils at 5 a.m. in the morning, and then since then had only had very, very minimal amounts from the bottle. The parents had also noticed that baby seemed progressively more sleepy, irritable when awake, and over the last 24 hours had noticed quite a big change in that she wasn't waking for her feeds. She hadn't passed urine since the night before, and so that would, at 3 p.m. in the afternoon, it's probably around 15 hours of not passing urine. No fevers, rash or vomiting, no other symptoms, no cough, no breathing difficulties. Bowels had opened yesterday. So, sorry, just trying to change the slide. So here we can see the weight trend. So birth weight of 3,060 grams. Day 5, we can see that she was losing weight. And then when we saw her on day 19, she weighed 2.75 kilograms. So she had lost 810 grams in 19 days. So to calculate weight loss, we use this formula and we calculated that she had lost 10.1% in 19 days, which according to NICE guidelines is significant. So babies that have lost more than 10% of birth weight, you want to be taking a feeding history, assessing, observing feeding, and then if there are any indications of illness, then you would want to do further investigations. But this baby had lost more than 10% of her birth weight. She was nearly at 3 weeks, she was at 19 days, and she had already trialled some input with feeding from the midwife. So this baby warranted a referral to paediatrics. So carrying on with the history, she was born at St George's at 41 plus 5 weeks. Mum had an emergency C-section due to a raised fetal heart rate, but no signs of infection during labour, no GBS. She had a normal newborn baby exam, apart from a sacral dimple for which she'd been referred to the neonatal team. She had an ultrasound by that point which showed possible spinal tethering, and was just for follow-up with the neonatal team. She was discharged 3 days after birth. Her heel prick on day 5 was normal, not on any medications and no drug allergies. So social history, this was the parents' first child, and they lived in quite a large household with 8 people in total, but everyone was well at home, no recent travel, no COVID contacts, and at this point, from the history, it was revealed that the parents were second cousins. Does anyone have any kind of say on why that might be significant? Yep, so more likely to have genetic conditions. Family history, nothing too significant. Paternal diabetes, and granddad had treated TB. Examination initially was fairly normal, obs were stable. She was sleeping initially, but upon waking seemed alert. Peripheries were a bit cool, but actually centrally she was warm and well perfused. Chest clear, heart sounds were normal, femoral pulses were present and equal, abdomen soft and non-tender, normal tone, and as mentioned before, she had this dimple at the bottom of her spine. So if you had seen this baby in A&E as a paediatric SHO, what do you think you'd want to do next? Yep, so everyone has put down a blood gas. So I think at this point it had been discussed with the paediatric reg, who has said definitely do a gas with some bloods, start NG feeding, given that she wasn't meeting her requirements, and admit. So everything had seemed, apart from the weight loss, fairly non-concerning so far, and then this was the blood gas that was obtained by the SHO. So does anyone want to talk through or interpret the blood gas? Yeah, so baby has a metabolic acidosis. She's got hyperkalemia, potassium's 10.5, hyponatremic, low glucose, raised lactate, low bicarb. So she's got metabolic acidosis. So what would you want to do next at this point? So this baby was seen, I think seen in minors in A&E. Just doing a presentation. Huh? Just doing a presentation. So baby was moved to majors and paediatric consultant was informed. Important to repeat the gas to make sure that the results, I said majors there, it was Sarah's right, they were moved to resus, not majors. So moved to resus, paediatric consultant was called, the gas was repeated and the results were exactly the same. Reassessed by the reg, again, nothing too concerning on the examination, but at this point the peds consultant examined and noticed that the baby had clitoromegaly. And then yes, Sarah's mentioned cardiac monitoring. So next question is, how would you want to, what are your thoughts on what this might be and how would you want to manage this patient? So what immediate management would you start? So it's concerning for congenital adrenal hyperplasia, and we know that from the gas, the metabolic acidosis with the hyperkalemia and hyponatremia. There's obviously quite a few issues with the gas if we go back. Right, sorry, I can't go back, but potassium of 10.5, sodium of 118, she's acidotic, low glucose. Obviously, there's a few things going on, and if you're in that situation, what would your thoughts be on what needs to be treated first? What would you give first? So as Sarah's mentioned, we think it's a salt wasting crisis secondary to CAH. And initial management, we want to get some access. We want to treat the hyperkalemia. We want to treat the fluid balance, and we want to treat the adrenal insufficiency. I think the team were unsure of what kind of order to go for. I think the endocrine consultant had recommended giving IV hydrocortisone quite quickly for the CAH, but I've got the order that things were given, and actually it does make sense. So saline nebs were given first, and that's probably whilst they were trying to gain access, that's to treat the hyperkalemia. Then the glucose was given, then the hydrocortisone for the CAH, sodium chloride was given next. Sorry, these aren't in order. And then the calcium gluconate was given last, and then later on insulin dextrose was given. But I think it's important to think about, if you're in this situation, what would you want to treat first? There's obviously a lot of things going in IV and you can't give everything at once. So obviously getting the potassium down is quite important, and also giving fluid boluses. Bloods as well, so the normal bloods, full blood count, using some clotting, and then some endocrine bloods to look for CAH. ECG and a cardiac monitor, as Sarah mentioned, and actually this baby did have signs of potassium toxicity on the ECG, so she had tall tented T waves and ST segment depression, and a PICU review, given that the baby was clearly quite unwell. So this baby was admitted onto PICU. In A&E, the gas was repeated and she was still hyperkalemic with potassium of 9, so she needed further treatment for the hyperkalemia. And once she got onto PICU, she had a CVC line inserted. She had continuous cardiac monitoring and hourly BBGs, and she did, for about, I think, 12 hours, need quite a few repeats. treatment for the hyperkalemia. The endocrine consultant had also recommended that the team keep the glucose on the higher side, and does anyone know why that might be? So it's basically to trigger insulin release, which will drive the potassium, lower the potassium. So it was another way to keep the potassium on the lower side. And then obviously monitoring urine output. And so luckily this baby did quite well. She was stepped down from PICU 3 days afterwards on oral hydrocortisone and fluticasone, which isn't there, and she was awaiting the results for her metabolic bloods, her genetic tests. And these are the results. So her genetic testing demonstrated that she was a female. She had 46XX chromosomes, and she had a 17 hydroxyprogesterone level of in excess of 1,300. So her hydroxy progesterone level was raised. So diagnosis, she has 21 hydroxylase deficiency, which is the most common type of CAH, and she had the salt wasting type. So I thought I would just talk through CAH and the different types and how they're managed. But just to finish off with her, she was well on the ward, her electrolytes stabilized, she was gaining weight, feeding well, smiling, reaching her expected milestones. So discharged home on oral hydrocortisone, fluticasone and sodium chloride, and then parents were educated on sick day rules, so doubling hydrocortisone during periods of unwellness, and in any severe acute infection they were given IM hydrocortisone to give. She initially was having twice weekly bloods to check her electrolytes with endocrine follow-up, and the spinal dimple, which turned out to be a separate issue, had some neonatal follow-up. So what is congenital adrenal hyperplasia? So it's a group of autosomal recessive disorders arising from inability for the adrenal glands to produce steroids. So given that it's autosomal recessive, consanguinity is something that's more likely is a risk for developing autosomal recessive disorders, and we can see in this case that the parents were second cousins. And therefore, with two parents who are a carrier of an autosomal recessive condition, their child will have a 25% chance of having the condition and a 50% chance of being a carrier. So we know that CAH results from a deficiency in one of the 5 major enzymes that contribute towards cortisol production. And the most common enzyme deficiency, as I said, is 21 hydroxylase deficiency, which counts for the majority of CAH cases, so above 90%. So I've just got up the steroid pathway here so we can see where 21 hydroxylase acts and where the pathway is kind of cut off from the deficiency in 21 hydroxylase. So you can see that it plays a part in producing aldosterone, mineral corticoids, cortisol, which is a glucocorticoid, and sex hormones. So genes will normally, the CYP21A2 gene mutation causes the deficiency, and if 21 hydroxylase is not present, this will therefore reduce the amount of aldosterone and cortisol produced, and it will also increase the 17 oxyhydroxylase progesterone, which is then shunted into the intact androgen pathway. So you can see here that the sex hormones will be increased. So build-up of androgens can cause abnormalities of sexual development, and then with the salt wasting type, the deficiency of aldosterone and cortisol can produce a salt wasting crisis. So I've just got a table up of all the different forms of CAH and highlighted the classic salt wasting 21-hydroxylase type. This accounts for 75% of the classic 21-hydroxylase deficiency. The other 25% is a simple viralizing form, which means that the females will present viralized, but there won't be any salt wasting. So with the 75% salt wasting, the females will be born with viralized genitalia. Males are generally unchanged, and they're at risk for salt wasting. So normally males are more at risk because they are not picked up at birth. There's no abnormalities found on the initial newborn baby examination, whereas females will sometimes have ambiguous genitalia picked up at birth, and that would be a reason to investigate for CAH. And then we can see here the typical features of raised potassium, low sodium, and the metabolic bloods. And just to mention, classic 21-hydroxylase deficiency presents before, well, process starts before birth. So at birth, babies will have viralized genitalia, the females will have viralized genitalia, whereas the non-classic 21-hydroxylase deficiency, babies will be present with normal genitalia at birth and then have hyperandrogenism postnatally and no salt wasting. And I've kind of put that there. And to explain why this happens, so it's basically the amount of the functional 21-hydroxylase enzyme. The amount of functional determines the severity of the disorder. So with the salt-losing form, people will have a gene mutation which results in completely non-functional enzyme, whereas individuals with a simple viralizing type will have gene mutations that allow production of low levels of enzymes, and then the non-classic is the least severe form, so they will have some moderate amount of enzyme. So looking at the features, it will normally present within 2 to 4 weeks of birth. It can present with a salt wasting crisis like we saw in our case. Things to look out for are hyponatremia and hyperkalemia like we saw in the gas. They'll also have raised renin, low aldosterone. They can present in hypovolemic shock. And actually, I think what was interesting about this case is that she looked quite well on initial examination. So I think it was quite a surprise to see a gas that was so abnormal. As I said, newborns will present with ambiguous genitalia in females, whereas males will have normal anatomy, but their internal reproductive organs are normal. They can also present with non-specific features, vomiting, dehydration, poor feeding, which again is similar to how this case presented, with kind of a slow history of poor feeding and weight loss. And that's quite important to keep in mind, that obviously there are lots of babies that might not gain their birth weight as quickly as you'd expect, but in those that are really not gaining as you'd expect or have quite a significant weight loss, it's important to think of more concerning causes rather than it just being an issue with breastfeeding or physiological. So for a diagnosis, the main blood test that you want to do is the 17-hydroxylase progesterone, which will be raised. They'll also have raised adrenal androgens, including progesterone in both males and females, androstenedione, sorry, I can't say that word. And then in females and prepubertal males, they'll also have raised testosterone and DHEA. As I said, in the salt wasting form, which is what this baby had, they'll have low aldosterone and raised renin, and you can also do gene testing. So they'll have, on both alleles, they'll have the mutation on the CYP21A2 gene. So management, we kind of quickly went through what this baby was managed with. So they all classic forms of 21-hydroxylase deficiency will need glucocorticoid replacement therapy. So that's for both the salt wasting type and the simple viralizing type. but the salt wasting form will also need mineral corticoid replacement and sometimes sodium chloride, like this baby did. Sometimes females might need genitoplasty or vaginal dilatation if they've been viralized at birth, and just some things to keep in mind that they'll need electrolytes monitored, steroid replacement therapy monitored, and there are a few things that I won't go into on this presentation, but they will need things like their weight, their bone mineral density monitored, and males are more at risk of getting testicular adrenal rest tumours, so that's something that will need to be monitored as they're growing as well. And there's also a role for genetic counselling. So just to finish off the presentation, I quickly wanted to talk about screening in neonates. So in countries like the USA, they do have CAH screening to identify infants with the classic form of 21-hydroxylase deficiency. This is, as I said before, more important generally in males because females will often have ambiguous genitalia at birth, so are more likely to be picked up, but also is useful for those females with ambiguous genitalia to confirm whether they've got CAH or investigate whether they've got CAH. So it's similar to a heel prick test in that it's just a blood spot measured on filter paper. However, they have quite high false positive rates, especially in low birth weight babies and preterm infants. So there's often second line tests with that are more accurate. Spectrometry is used to confirm the diagnosis. But we don't have the CAH screening in the UK. And there was actually a recent review by the UK National Screening Committee in April this year, who looked at the incidence of CAH in the UK population, looked at the age of onset or presentation, and also looked at the accuracy of available screening tests. And they have, again, as before, not recommended screening because there isn't enough evidence whether the screening would identify those babies in time and whether the screening test would accurately find all the cases. So I've just put some kind of general learning points from the presentation. There's quite a wide differential for weight loss in newborns, and as a paediatrician, it's important to recognise what is significant in weight loss in the newborn, so more than 10% that they're not regaining by 3 weeks. I thought it was quite interesting that CAH can present with such non-specific symptoms. So this baby just initially presented with poor feeding, and talking to one of the regs the other day, we were discussing how actually if this baby had come in during the week, they might have been seen on Blue Sky, which is our assessment unit for more well children. So if this baby had come in on the week with weight loss, she might have actually been reviewed in Blue Sky rather than A&E, and we thought that's quite interesting, the fact that actually this baby was quite unwell and needed so much management and picky stay. And hopefully you learned some more specific information on CAH, how to manage it, how to identify it.
Thank you very much, Jordan. That was absolutely fantastic. A really interesting case. We're going to have to move on, if that's all right, to Dr. Hulse's teaching. But if anyone has any questions, if you put it into the chat, and I can make sure that it's relayed back. Without further ado, I'm going to hand over to Dr. Hulse. Thank you.
Thank you.
Thank you very much. Can you hear me, Emma? Is that right? Yeah. Thank you, Jordan. That was a nice case. Can I just make 2 or 3 comments before I start? That was a very typical presentation of a girl with salt-losing CAH. Just 2 or 3 things I wanted to say. One was the electrolyte profile with the hyponatremia, hyperkalemia, and metabolic acidosis is also exactly what you see in salt-losing renal failure as well. And of course, on a blood gas, you don't get a creatinine and a urea. So in fact, before we had screening, ultrasound screening for renal abnormalities, which effectively what happens, a renal dysfunction was much more common than adrenal dysfunction. So a creatinine, a urea, or even an ultrasound would really be quite useful to make sure it's adrenal and not renal. The second thing, just as I wanted to say, is you have to be a bit cautious about making a diagnosis on a 17-hydroxyprogesterone level, because a sick child with hyponatremia from whatever cause will have quite a raised 17-OHP because it's a rate limiting step, but not have CAH. And I've seen misdiagnoses before. So a 17-OHP of 50 or 60 even might not be unusual, whereas of course this baby had it in the thousands. So it's just a couple of practice points. The last thing just to say was that, of course, non-salt losing virilizing males do get symptomatic and present with precocious puberty, actually. So they just present in a rather different way. Anyway, just a few comments. I will attempt to screen share, hopefully now. Which was here, has now disappeared.
It should be at the bottom of the screen.
Should be at the bottom of the screen. It was here earlier, wasn't it, Emma? It's just not appeared on my list.
I don't know whether Jordine has to give up the presenting function.
I think that may be what it is.
She should have done, I think.
Has she?
I switched mine off.
Okay, I have a feeling
At the bottom that says
I have a
screen.
feeling my PowerPoint has switched itself off. Sorry about this.
I can share it if you would rather. I did.
1 minute. This is ridiculous.
Perfect. Absolutely fantastic.
Is that working now?
Yes, that's perfect.
Hopefully. It seemed to shut down. Right, are we there now?
Not quite, no. I can see your screen, but it's I've got the LSP endocrine teaching.
Screen sharing for some reason.
If not, I can share it on my screen and you can just tell me when to change slide.
I think you better do that. I don't know why it suddenly worked perfectly earlier.
Okay. Can you see it now?
No. Oh, hang on. Are you getting it now?
Yes. Oh, no, we just lost it.
It's come up perfectly on mine.
I can't see it. Oh, everyone else can. That's fine.
Yeah, I can see it.
Fine.
It should say the clinical examination endocrinology. Yes? Is everybody else saying it, but not you?
Yeah, got it.
Go for it.
Okay. I subtitle. Time is a bit short, so I'm going to, or I subtitle this "What you might see on miss on a telephone consultation." This is actually adapted from some MRCP teaching, so I'm not going to have time to do all of it. I'm just going to start with a sort of digression where I was asked to talk about common diseases. And there's this sort of concept that you learn about common diseases, ST1 to 3, and then you learn about rare diseases. And I think this is rubbish, actually. Obviously, you learn a lot about common diseases when you're in the S or SHO stage, and you should be relatively proficient by the time you've got to ST3. But actually, you also start to learn about rare diseases right from the beginning as well. And I bet all of you on this call have seen a large number of children with rare diseases. So what is a rare disease? The EU suggested sort of 1 in 2 or 3,000. In fact, when you look, rare diseases are common. So we have about 3,000 genes associated with human diseases. There are about 8,000 rare diseases in children. 75% of genetic diseases occur in children. There are at least 600 or more skeletal dysplasias. So you're actually going to see loads of rare diseases, but of course you'll only see in 1s or 2s of those. So just because it's rare, it doesn't mean it doesn't matter. And for parents, they're not terribly impressed when you've made a diagnosis and very proud of yourself because it's a rare disease, because what they want is their child treated. So you carry on learning about rare diseases in pediatrics forever, and you start right at the beginning. So I'm including some rare diseases in my defense. But you've got lots of things to help. There's OMIM, which is a great resource. This is online Mendelian inheritance in man. And if you want to know about genetic diseases, it'll tell you everything you need to know. So now I won't advance the slide. Right. So what about clinical exam? One of the things that slightly gets me is one of the commonest things I get is people ringing me and asking me about thyroid function test and telling me the TSH, telling me the T4. And I say, well, what was the thyroid like? And they say, oh, we didn't actually examine the thyroid. So there's plenty of clinical examination in endocrinology. And it's no different from the rest of clinical medicine. So total observational skills, all my neurological examinations have mostly been done, me just sitting watching what's going on. So recognizing a child, the way they behave as being autistic. So a thin, tall child who's lost lots of weight and is terribly fiddly and fidgets the whole time may well be thyrotoxic. And using all available clues. So if you've got a medic alert bracelet, you happen to notice. And then, of course, there's about developing clinical skills. And I'm going to talk a bit about examining the thyroid. And lastly, it's putting all that lot together and actually making sense of clinical signs as you elicit them. And I could say a lot more about that, but time is short, so let's carry on. So I'm just going to pick out a few things. I don't think there's going to be time to go through everything, but these are things you won't see if you're doing a telephone consult, but you will see if you see someone in clinical practice or in an exam or whatever. So I did say I'd talk about rare diseases, but let's talk about some common diseases. Type 1 diabetes is well under 2,000, it's sort of around about 600. Type 2 is increasing, and obesity, of course, is very common. So things to look for. So on the left-hand side, you can see someone's fingers, and you can see all the little marks from blood glucose testing. Interestingly, of course, we actually teach that you should prick the side of your fingers, not the palp of the fingers, because that's more painful, but you can see this child. But one thing you immediately know is that there's been lots of testing going on. And then you can look at injection sites, and you can see here marks. And most children who've been taking insulin will have 1 or 2 bruises around, and you can see this child's got lots of marks. And then lastly, we've got common injection sites at the bottom. So I'm just trying to advance the slide, right. One of the other things that would be routine in someone with diabetes and then looking at sites is looking and seeing as if they have lipohypertrophy, which is extremely common and of course extremely important, because one of the things that happens if you get fatty lumps is that you get poor insulin absorption, and it usually indicates overuse of sites. Less commonly, and I don't know why this sometimes happens, you get lipoatrophy. And I've also seen the same thing occurring very occasionally in children on insulin pumps, both lipohypertrophy and lipoatrophy. Well, that's much less common when you're on a pump, because there's not this sort of depot of insulin injected into one place. It's a much smaller amount of insulin. Interestingly, children who are on growth hormone, which is our second most common cause of needing daily injections, tend not to get lipohypertrophy or lipoatrophy, which is interesting. And then, of course, if you've got diabetes, plenty of other things you'll see when you examine. You can see pumps. We've seen a couple of different types of pumps here, and you may see continuous glucose monitoring. And in the bottom, you can see a couple of rather well-known people. Theresa May was, of course, misdiagnosed as having type 2 diabetes, but actually had type 1 diabetes with her Libra patch for swiping for glucose measurements. And lastly, any condition which can affect child's awareness or for which they might need urgent attention, like adrenal failure or something like that, they may be wearing a medical alert bracelet. So there's quite a lot to see and look for when you've got someone with diabetes. And lastly, something that is very important, and I suspect that many of you will have seen but may not have recognized, you've seen it, is Acanthosis nigricans. So this is a sort of velvety change to the skin. It sort of feels like velvet. It can become quite polyps. It's nearly always in the neck, the axilla or the groin, and parents always say it looks like dirt that doesn't wash off, and that's exactly what it's like. So it's more common in children or young people who are overweight or obese. It can occur without, because you can get various genetic forms of insulin resistance, and it is extremely common and rising in prevalence. And it's nearly always associated with insulin resistance, and it may lead on to type 2 diabetes. So I'm now going to move on to talk a little bit about the thyroid. I would tell you about this girl on the right, but I won't because there's not enough time. So the thyroid examination, one of the first things you've got to sort out is their thyroid status. Is someone hyperthyroid? Are they hypothyroid? And I was just going to say that actually hypothyroidism is a very unusual cause of failure to thrive. It's in all the textbooks as causing the failure to thrive, but it actually doesn't. Just referencing the previous presentation. You need to learn to be able to examine the thyroid properly, notice if there are any scars, and then, of course, there's very importantly in the child with an overactive thyroid, Thyroid Eye Signs, and we'll go into those in a bit more detail. And then, of course, associated findings. So it's an autoimmune disease, and you may have other autoimmune diseases like vitiligo or alopecia. I remember once seeing a young person rather similar to the one I showed you in the picture, who I was fairly convinced was profoundly hypothyroid, sent off to get some blood tests done, which hadn't been done that far. At that point, Dad leant over and shook me by the hand. I noticed he got vitiligo. So the autoimmune disease may not be in the same family, maybe in a different family member. So just going through the things when you're looking for thyroid status, you're wanting to see how their hands feel. Are they hot? Are they cold? Are there the palmar erythema? Do they have a tremor? Are they tachycardic? Are they bradycardic? And have they got brisk reflexes? These are all things that are going to help you towards thyroid status. And a very careful examination for thyroid scars, because actually the neck, the skin around the neck, particularly in white children, heals very well. And after 2 or 3 days, 2 or 3 years after a thyroidectomy, for example, you may hardly see a scar at all. So a good look for any scars if you're in an exam situation. And then there are thyroid eye signs. There is Acanthosis, where the eye is actually displaced forwards, as you can see in the top picture. And you need to look from above, look from the sides. And then different is exophthalmos, where the sclera is visible from above. So that is from lid retraction. But of course, the other thing you're looking for is looking when the eye moves downwards, when you're following eye movements, if there's lid lag. So these are different things, and these are things all associated with ophthalmic eye disease, associated with Graves' disease. So basically, if you're thyrotoxic, you've got eye signs, you've got Graves' disease, regardless of what your antibodies are. And the other thing is, I've mentioned often thyroids aren't the neck is properly examined. You have a lump in the neck. Is this really a thyroid? Is it a thyroglossal cyst? Is it midline and so on? You need to learn to palpate. There's nothing like palpating the thyroid, and lots of normal children, when you have the opportunity to feel what a normal thyroid is like. Thyroid's palpable in pretty well everybody. Sometimes it's difficult if they're quite obese with the amount of fat, but you can even learn to palpate the thyroid in neonates and get quite a good idea in a child, in a baby. If there's a central mass that may be a pyramidal load, is it symmetrical? Is it smooth? Is it lumpy? Is it soft? Is it firm? Is there associated lymphadenopathy? Are there any voice changes? These are all really important things. And in the past, I've diagnosed a thyroid cancer simply from the feel of the thyroid. It has felt much too hard and lumpy and very unpleasant, and obviously warranted an urgent ultrasound. I probably going to not have time to go through all these, so I'm just going to do the short stature bit, and then I probably leave the skin running out of time and have 5 minutes at the end. So let's think about height, but in this lovely engraving by Dürer from 1557, you can see of someone with achondroplasia. You can see there are loads of different measurements you can take, and if you're a sort of measurement fanatic like myself, you get interested in these things. So when children are growing abnormally, what do you look for? Well, you have to distinguish between whether you're just short, because you should be short, could be short, but growing with a normal velocity, or whether you're growing too slowly or less commonly growing too fast. So it's a distinction between your height and your growth rate, and we'll talk a bit about that in a minute. So that's the first thing you can look at, see how you're growing according to centiles. You can look at height-weight relationships. Are you too fat or are you too thin? That's effectively BMI, and I'll show you a BMI chart in a minute. And the third thing you can look at is body proportion. So you shorten the legs and shorten the back. And if you put all those things together, the growth from the charts and the orxology, you can very often get pretty close to a diagnosis without doing any tests. So here is a typical growth chart. I could talk about, there's a huge amount to talk about on the growth chart. One of the things I will just point out, there's two things I'll just point out, is that in the mid-childhood section here, you follow the centile lines pretty well. You cross centiles in the first year or two of life because you're moving from a height that is determined by birth conditions to a more genetically determined one. And then, of course, you can cross centiles at puberty, depending on whether you're an early or a late developer. So the lines diverge, so small children grow more slowly than big children. And just to give you an idea, if you're following these lower centiles, you're growing at about 5 centimeters a year. You're following other upper centiles, you're growing at about 7 centimeters per year. And then I talked about that height-weight relationship, and I put up here a BMI chart. And you can see that you could have a BMI of 25, which would be the borderline kilograms per meter square for being overweight as an adult. But as a 4-year-old, you would be severely obese. So you have to relate BMI to growth. Body proportions, you can be short in the leg. There's a long list of things that tend to cause disproportionate leg growth. Hypothyroidism, rickets is probably one of the most, a lot of skeletal dysplasias, but not all of them. Turner syndrome. Looking at the head growth, you can make microcephalic, macrocephalic, or normal. And then you can look at the spine. You could be short in the spine. This is less easy to recognize. The commonest, of course, is actually scoliosis, other skeletal abnormalities, a number of skeletal dysplasias. And then you could be long in the legs. So these different ways that your growth is affected by growth disorders. And we have a tool, which is a sitting height chart, which I haven't got time to go into, whereby you can look at body proportions. And what you can see on this is that children don't grow proportionately. The sitting height lines are not parallel to the leg length lines. So we're relatively longer in the back when we're younger, and then we get longer in the legs later. So a couple of clinical pictures. The child on the left, of course, has achondroplasia. The child on the right has hypochondroplasia. These are actually the same gene, FGFR3, but different mutations within it. So I'm going to take about 2 more minutes, if I may, Emma, and then I will stop. So a very quick way of diagnosing and thinking about short stature. So if you're short and overweight, you could well have an endocrine cause. Hypothyroidism, growth hormone deficiency, glucocorticoid excess, or Cushing's for whatever reason. The picture here of a child with severe growth hormone deficiency all tend to cause relatively overweight compared with your height. So the short fat child always needs investigation and thinking of endocrine causes. Whereas if you're short and thin, there's a very much longer list. Many of these things have been and no longer so because of improved nutrition, the use of peg tubes and so on. But you're thinking here much more of things like celiac disease, Crohn's disease, malabsorption, malnutrition, neglect, and particularly cerebral palsy. So a long list of things. So it's just a different way of thinking of things. There are a number of syndromes that are associated, and I put 5 here. And I'm just going to mention very briefly Russell-Silver syndrome or Silver-Russell syndrome because it's one of the more common ones. There's a situation where you have prenatal growth failure and no catch-up growth. You have a characteristic face, which I will show you, often have lay symmetry. And this is a very interesting disorder because we know a lot about the genetics. There isn't time to go into. So here are a couple of children with Russell-Silver syndrome and the typical triangular face, rather turned up nose and small jaw, you see. Girls with Turner syndrome often can look pretty normal. Sometimes they have a more characteristic face. Sometimes you can recognize them, not always. The growth chart you can see on the left is very distinctive, and the girl on the right's got cubitus valgus. Well, one of the things that's really helpful with children with syndrome and short stature and possible syndromes is a good look at the hand. And typically, girls with Turner syndrome have very unusual nails, and the nails often turn upwards, not downwards, as in most people. And there's a list of, I think that probably time is not, I'm going to miss that slide out. And the last one I will just mention, one of the more common syndromes is Noonan syndrome. Rotated ears, down sloping eyes, very characteristic blue eyes. That's very not well described, but most of the children I've seen with Noonans have these very blue eyes. An absolutely classic and usually diagnostic form of congenital heart disease. Short stature, we have charts, a tendency to bleeding and occasionally leukemia, cryptorchidism, and very variable intelligence. So I'm going to stop now. I have overrun by 2 minutes, my apologies. I'm going to have to leave the skin till some other time. But that's just a quick run through some of the clinical features you might see in endocrine conditions. Thank you.
Thank you very much. That was absolutely fantastic and very, very relevant for clinical exams for the MRC-PCH. We're going to do our quick MCQ quiz, so I'm going to hand over to Sarah. Please do fill out the feedback, and any questions at all, let me know, and I can email Tony and get a reply to you. Okay?
Okay, can everyone hear me? And can everyone see my giant game screen? So it's just a quick 5-minute quiz just to round out the session. All you need to do on your smartphone or on your computer is go to kahoot.it and then type in this game pin here. It's only 5 questions and each question takes about 30 seconds. So it's just to kind of round out the session. So I'll give it a few minutes for some people to get logged in. You don't have to put your own name, you can do it anonymously. So if you want to do it anonymously, maybe put in your favorite hormone, and that could be your nickname for the session today. T4, an excellent hormone. How obscure is it going to get? Still 18 people here. There's more people who can come into this. Let's see, at least 5 or 6 of you. I'm going to give it 1 more minute and then we're going to play. Excellent. Just endo, why not? Keep it simple. Okay, 10 seconds and then we're going to start playing. I promise it's fun. Okay, 5, 4, 3, 2, 1. Okay. So the questions are going to come up and then you get points for answering correctly and answering quickly. So 5 questions. Which of the following blood gas results would most suggest CAH? Remember, it's points for being quick and points for being right. Got 9 seconds left to get your answer in. Very good indeed. All correct. So that scoring is going to come down to whoever did it fastest. Oh, T4 is in there. Very good. Okay, next question. Remember, the faster you answer, the more points you get, even if you get the right answer. Some very tense music now. Excellent. So again, one person said 17 alpha hydroxylase. That is something that you can see, a 17 alpha hydroxylase deficiency, but 21 hydroxylase is the more common one. How has that affected the scores? T4 is still in the lead, but estrogen very, very close behind. Okay, we're at the halfway point. Jordine mentioned this earlier on, what you might find if you were doing the baby check for a baby boy who had CAH. What would you see? Worth thinking about when you're doing those postnatal ward shifts. 1 second. Yeah, very good. So as we were saying, in baby girls, you often get the kind of virilized or ambiguous genitalia. You get clitoromegaly. In a male infant, often the genitals are normal. You can see some subtle abnormalities, but not any of the ones that I've listed here usually. How's that affected the scores? Oh, estrogen has knocked T4 off the top spot. Let's have a look at the next question. There's 2 more to go. There's still everything to play for. So which of these test results would be compatible with the diagnosis of 21 hydroxylase deficient CAH? Lots of things here that your tertiary centre might have asked you to send. 5 seconds to choose one. Very good indeed. You actually often have a high plasma renin, but everyone else very correct. Okay, before the last question, where are we at? It's still pretty much a battle between estrogen and T4. Let's have a look at that final question. So which additional treatment would be necessary in your salt wasting forms of CAH? Which one of these? Remember, quicker answers get more points. 10 seconds left. So there's 1 or 2 people left to answer. Very good, yeah. So babies with salt wasting CAH would also need some mineralocorticoid supplementation. Very good. So let's see who our winners are for this month's case exchange. In 3rd place, testosterone. Very good, very good. T4, number 2, a valiant effort, but overtaken halfway. And estrogen was the winner.